Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen, and I thank you so much for listening today. Go check out reallifepharmacology.com. You can get a free 31-page PDF, great study guide, quick summary, review of the top 200 drugs, clinical practice pearls, as well as things that show up on board exams a lot. Same thing if you're in pharmacy school, med school, nursing school, and taking pharmacology. You're going to see a lot of the information there potentially show up on pharmacology exams throughout your career too. So again, based on my experience, things I've seen in practice, as well as thoughts from others in academia as well. So go check that out, subscribe. Get that absolutely for free, reallifepharmacology.com. We also give you updates as to when we have new podcasts and content episodes available there as well. So go do that at reallifepharmacology.com. And with that, let's get into the drug of the day today, and that is Sumatriptan. Primary brand name you're going to hear in clinical practice is Imitrex. I definitely see this medication used periodically. By far, the most common situation I see it used for is acute migraine treatment. With that said, I have seen it used for cluster headaches as well. If you remember, in cluster headaches, oxygen is important treatment, but I have seen triptans used in combination, specifically Sumatriptan, used in combination for relieving some of the symptoms of cluster headache as well. Mechanistically, this is classified as a triptan, and it is a serotonin agonist, and specifically as an agonist at the 5-HT1B and 1D receptors. And primarily what's going to result from this, and what's likely theorized to be the benefit, is vasoconstriction and a reduction of inflammation, which could obviously make headaches worse. That vasodilation has been thought to cause headache pain or be associated with that. With that said, it's a lot of theories in the migraine world. The brain is a complicated structure, and so I don't think it's 100% figured out exactly how a migraine happens, why a migraine happens, what causes a migraine. There's a lot to learn still, but the theories there that vasoconstriction from these drugs and reduction of inflammation may help manage that migraine and abort a migraine or reduce the pain and severity there. I did want to mention triptans generally aren't used first in migraine therapy unless it's kind of more moderate to severe. For those milder cases, we're going to generally use simple analgesics like acetaminophen and NSAIDs, and as those don't work or as the progression of migraine gets more severe, then we start to lean into the triptans. Other important things I think to pay attention to, we generally want to avoid using no more than 9 doses per month. Kind of that magic number is 10 is probably easier to remember. So less than 10 days per month we want to use abortive therapy. These drugs, maybe more so other drugs, can cause rebound headaches, or medication overuse headaches, where we use too much of the medication and then the headache remains and continues to linger and potentially even get worse in some situations. So again, we don't want to use abortive short-term acute migraine treatment on a chronic basis, because that's going to potentially lead to more problems than it does good there. Dosing of Sumatriptan, 50 to 100 milligrams, and we can repeat that dose 2 hours or later if the patient is still struggling with migraine symptoms. So generally a max of 200 milligrams per day, and depending upon the patient, they're going to use a 50 milligram dose or a 100 milligram dose. Pharmacokinetics is important. There are multiple dosage forms of Sumatriptan. We've got oral, we've got nasal, we've got sub-Q. So this is going to be selected based upon pretty much what the patient likes and what's beneficial to them. And also ease of administration, of course. So a good example of a patient that you might avoid the oral route is a patient that has a lot of nausea and vomiting associated with their migraine. If they're vomiting, they're throwing that pill right back up. They're not going to get the dose, and they're not going to get the relief. With that said, if somebody has nausea and vomiting, we might lean on more nasal administration or sub-Q administration. Okay, I did want to mention pharmacokinetics, and this generally holds true, I think, for any medication and any medication administration. Oral's generally going to be slower. Nasal is a little bit quicker, and sub-Q and obviously IV is the fastest route of administration for a medication. So specifically with sumatriptan, oral is approximately 30 minutes for the onset. Nasal's 15 to 30 minutes, in that ballpark. Sub-Q is 10-minute onset approximately. All right, let's talk about adverse effects. So first thing I want you to think of is vasoconstriction. So that's one of the key characteristics in potential benefit in using a drug like sumatriptan in migraine treatment. But vasoconstriction is generally not a good thing when it comes to other vessels, and particularly you think of the heart and brain and situations like that. Vasoconstriction is a bad thing and can lead to heart attacks and strokes and things like that. And indeed, that is a potential concern with the use of triptans. Now, younger patients at low cardiovascular risk, we typically aren't going to worry about that as much. Now, if you've got a patient with multiple heart attack history, stroke history, TIA history, this is a concern and probably a situation where we're going to avoid triptans, and they are contraindicated in situations like that according to the package insert. So really got to look at cardiovascular risks. If you are struggling to kind of gauge that assessment and what other options we have for migraine treatment, that type of thing, it may help to get cardiology involved and see what their take is on their cardiovascular risk. But again, if you see that patient history, you see them on antiplatelet agents, anticoagulant type agents for prevention of strokes, preventions of heart attack, things like that. That is a concern with triptans, that it may increase that risk. Another thing, cardiovascular-wise, cardiac-wise, I guess, QT prolongation. So there has been risk associated with using the triptans in prolonging that QT interval. So if you've got a patient at baseline that's already at risk due to other risk factors, and if you go back to the amiodarone podcast, I talk about a lot of those risks that may increase the risk for QT prolongation. Definitely go check that out. But triptans, like sumatriptan, can cause that issue or potentially make a cardiovascular event more probable there. Other adverse effects, dizziness, drowsiness, those are kind of more nuisance things in general. And then we've got to remember the serotonin agonist action. So serotonin syndrome is a consideration there as well. And then if you think about each of those individual dosage forms, so local irritation, injection site reactions, things like that can happen, obviously, with the sub-Q. Nasal discomfort, nasal irritation can happen with the nasal dosage form. GI upset can happen, maybe more so with the oral administration there. So again, all those adverse effects kind of go along with the way we're giving that drug. All right, so let's take a quick break from our sponsor and we'll wrap up with drug interactions. If you're in the market for pharmacist board certification study material like BCPS, BCACP, BCMTMS, geriatric certification, NAPLEX exam, go check out meded101.com/store, STORE. If you're a nurse, dietitian, med student, physician, nurse practitioner, PA, we've got all sorts of books, Audible books as well, meded101.com/store. Latest and greatest has been Perils of Polypharmacy. A lot of people liked it. I've been getting a lot of good reviews on that book. A lot of experiences from my practice in primarily geriatrics and polypharmacy, reducing meds. I talk about strategies there, as well as the prescribing cascade. A lot of common examples there. So again, go check that out, Perils of Polypharmacy. It's on Amazon. But yeah, all those links you're going to find at meded101.com/store, STORE. And as I finish up on drug interactions, I want to, of course, mention my 2 books. I've got a food drug interaction book that you can find at meded101.com/store. And I've got a common drug interactions in primary care book as well. Again, they've both been fairly highly rated. I've been fortunate to have a lot of people enjoy and I think benefit from those books. So again, go check those out, meded101.com/store. Okay, so getting into our drug interactions, there aren't a ton of drug interactions with triptans as far as, thinking about like enzymes like CYP2D6 or 3A4, that type of thing. Usually that's not terribly concerning with sumatriptan, but there definitely are a few to consider. And the 2 primary things are MAOIs, which again aren't used terribly often. They're an older school agent that can be used for refractory depression. But certainly we have some serotonin risks and things like that with that class. And then the other serotonergic agents, we can have some additive effects. So SSRIs, TCAs, tramadol, SNRIs, these can all potentially increase the role of serotonin in the brain and increase the risk for serotonin syndrome. Okay, and so when I think about these type of drug interactions, I think about that cumulative effect. So if I've got a patient on, let's say, an SNRI like duloxetine 30 milligrams, am I really worried about serotonin syndrome if a patient takes a triptan a couple times a month? No, probably not. Okay. Now, do I have a patient on a TCA and maybe they're taking tramadol and they're higher dosages, and now we're taking more and more frequent sumatriptan use? That's a situation where it probably should be coming a little bit more into focus, and we maybe should think about that a little bit further. So again, serotonin syndrome is extremely, extremely rare. I've only seen a couple of cases in 10 plus years of practice, but it is, relatively serious as well. So it's important to think about, but, in general, you want to look at the dosages, look at the medications they're on, how frequently they're taking it, and really kind of do that risk assessment. All right, so I think that's going to wrap up the podcast for today. Thank you so much for listening. Leave us a rating review on iTunes or wherever you're listening. Greatly appreciated. For those of you that have already done that, it helps us grow this podcast. Another way to help grow this podcast is shoot a friend an email with the podcast link, URL, or reallifepharmacology.com. Help them get better at medication management, medication safety, and just learning pharmacology in general. So again, rating and review on iTunes and sharing it via email or whatever else you want to do so, social media. That has been greatly appreciative, and it has grown the podcast far beyond anything I have ever imagined. If you want to help keep this podcast free, go to go to meded101.com/store, STORE. Your purchases there go directly to support this podcast. If you want to track me down, suggestions, comments, questions about study materials, anything like that, mededucation101@gmail.com, or you can track me down, Eric Christensen, PharmD, BCGP, BCPS on LinkedIn. All right. Thank you guys so much for listening. Take care. Hope you have a great rest of your day.